from Tulane University to teach us about this.
Thanks, Jennifer. Now I'm nervous that my figures aren't going to show up, but and I'm sure that'll fluster me. Let me just start off by saying how great it is to be here, and a big thanks to PLOS Medicine, the editor at PLOS Medicine that we dealt with. Lucy Chappelle was great to work with, and then to Jennifer and organizing all of this and getting this collection to life was a big thanks. Also, just a thank you to my collaborators and colleagues in Zambia, both at the National Malaria Control Center, as well as in PATH Masepa, and then my colleagues at Tulane in the Center for Applied Malaria Research and Evaluation. So, household surveys are used to measure if a child had blood taken for a malaria rapid diagnostic test, refer to that as RDT from here on out, and if the child received first-line antimalarial treatment. So the figure here I stole from the Rollback Malaria Progress and Impact series, and it just shows survey data from 2005 to 2010 and illustrates how these large-scale surveys are used to track progress in access to antimalarial treatments. So there's two primary indicators that we currently measure with these surveys. The first is the proportion of children under 5 with a fever in the last 2 weeks who had blood taken with a finger or heel stick, and this is implied, we don't ask this directly, but it's getting at was a malaria diagnostic test performed, either microscopy or an RDT. And then secondly, we measure the proportion of children under 5 with fever in the last 2 weeks who received an effective antimalarial. And in this case, I'm referring to artemisinin-based combination therapy, and I'll refer to that as an ACT. But current diagnosis and malaria case management indicators are all subject to caregiver recall of what happened during the fever episode. And this definitely has potential for information error and bias. We don't know what happened during the clinic interview, the clinic sick child visit. All we know is the mother's recall and account of what happened. And until now, these indicators and their means of measurement have yet to be validated against a gold standard to assess accuracy of caregiver recall. So we had 3 objectives with this study, all compared to a gold standard of direct observation of a child's sick visit for a fever at a health facility. We aim to assess caregiver accuracy 2 weeks later in recalling whether the child received her finger or heel stick. Again, this is for a rapid diagnostic test. Whether the caregiver recalled the results of the malaria diagnostic test or a malaria diagnosis. And these are, let me add, these are 2 new questions that we've added to try to get at, can we limit the indicator for treatment of fevers to treatment of children with a fever related to a malaria parasite infection, which would be very helpful if we could do that. And then lastly, to assess the recall of whether the child received a malaria treatment and what that treatment consisted of. So the study site, we included 5 public health facilities in the Takehome district of Western Province of Zambia. We had 1 urban facility and 4 rural facilities. We hoped that these were somewhat representative of other health facilities in Zambia, but they were chosen purposefully to get the right sample size with the number of patients and cases that went through. As much of Zambia is at this point, all were covered by the new rapid malaria reporting system. So Jennifer outlined this pretty well, but I'll take you through how we did it again here. So direct observation of malaria diagnosis and treatment at the clinic was used. And so these are all children attending one of these 5 facilities for a sick visit for fever. We then enrolled their caregivers into the study, and we went out and we completed a questionnaire at their home between 1 and 14 days later. And the reason we chose 1 and 14 days was to replicate the recall period of 2 weeks that you would get from either a DHS, a mix, or a malaria indicator survey. This then allows us to assess the accuracy of caregiver recall of malaria diagnosis and treatment. So we used standard MIS, DHS, or mix questionnaire, slightly different. This is based on the MIS and the mix. This is just a snapshot of the first set of questions going through fever. Then there's a whole series of questions on what was done to manage that fever. And then we added questions on result of malaria diagnostic test. So did the mother know what the test result was, if they had a fever, finger or heel stick? And then among all mothers, did they get a diagnosis of malaria or did they not? So we defined sensitivity of recall in this study as the proportion of caregivers who correctly recalled if the child received a finger heel stick, malaria diagnosis, and ACT. And this is based on a questionnaire of those who actually received them based on direct observation. Then specificity of recall is defined as the proportion of caregivers who correctly recalled that a child did not receive a finger heel stick, malaria diagnosis, and ACT from the questionnaire of those who did not receive them. Again, direct observation, and then accuracy is a combination of both of these, sensitivity and specificity. And again, as Jennifer put it, it's the proportion of caregivers who got it right. So just to go through some key results, recall of a fever. Remember, all of the children in the study had a fever, all 601 of them. And as one would expect, mothers are pretty good, or caregivers are pretty good at recall that their child actually had a fever. Only 4 out of 100 on average didn't recall during the interview that their child had a fever. The other encouraging result was that recall of any antimalarial and recall that drug was an ACT, and in Zambia, the first-line drug is coartem, which is a type of ACT, and it was used, and it was probably used in over 95% of treatment that was given in this study. And assessing the sensitivity and specificity, anything above 80%, you're doing pretty darn good, and the accuracy of 84% and 85% respectively for any antimalarial and ACT given was quite encouraging. However, we did find suboptimal results for some of the, the finger heel stick, recall of finger heel stick that was done is currently in the Malaria Indicator Survey, the DHS, and I believe the mix. And it had poor sensitivity but high specificity. And that was very similar to the recall of whether or not, whether the mother recalls the actual test result of those that had her finger or heel stick, low sensitivity, quite good specificity. And what this really means is that mothers and caregivers are forgetting that something happened, the event happened, but they're not saying that they got a finger heel stick or their child did, or they had a positive malaria test when they really didn't, the high specificity. And then we had suboptimal recall of malaria diagnosis with modest sensitivity and specificity of around 75% with a according accuracy of around 75%. So I'm going to spend a little bit of time on this figure, and I'm glad it showed up. This would have been tough to go through. So one of the things we like to do with sensitivity specificity from individual respondents is then apply those observations to what we would expect to get if we measured coverage in the population, similar to what Harry went through in his previous presentation. And so if we look at finger heel stick for an example, your y-axis, your vertical axis, is going to be the coverage that you would get from a household survey with the sensitivity and specificity that we observed for this set of questions here in this study across the x-axis, which is the population, the coverage that truly exists in a population. Now, so if you had perfect sensitivity and specificity, you would get the diagonal black line in the middle, because if it was 80% coverage of a finger heel stick in reality in a country, you had perfect sensitivity specificity, that's exactly what the survey would show. And based on the sensitivity and specificity here, what you see is because of the low sensitivity but pretty good specificity, as coverage ramps up for diagnostics, which it is across most malaria countries in Africa, you're going to start getting a pretty good underestimation of the proportion of children that receive this intervention. Similar results for a positive malaria test of those children that got a finger or heel stick. You're going to get pretty good underestimations as coverage increases. And then for malaria diagnosis, because it had suboptimal sensitivity and specificity, at low coverage levels, you're going to get an overestimation, and at high coverage levels in the population, you're going to get a bit of an underestimation. And as pretty good sensitivity and specificity for the recall that an ACT was given for the fever, that you're going to get pretty good estimates from household surveys, which is very encouraging. So some of the key conclusions. In this setting, sensitivity and specificity of caregiver recall of finger heel stick test results in malaria diagnosis were suboptimal. Specificity was better for finger heel stick and test result, which is encouraging. That is to say that women aren't saying that their children received those when they didn't. But specificity wasn't so great with malaria diagnosis either. Sensitivity and specificity performed reasonably well for caregiver recall of ACT. An antimalarial was given. And then we actually, these are just some of the results, we poked and prodded these data to look at relationships between caregiver, sociodemographic characteristic, access to healthcare issues, socioeconomic status at the household level, and to look and see what sort of characteristics were related to a mother accurately recalling events. And if a child received a laboratory diagnosis, it appears to improve recall of malaria diagnosis. So that's recalling that the diagnosis was malaria and that an AC treatment was given. And this is encouraging because we are scaling up access to laboratory diagnosis across Africa. At least that's the goal. So the take-home message is, for tracking progress towards targets for prompt, effective treatment of malaria, household survey data should only be used for measuring coverage of treatment seeking for fevers, that is to say, what happened when they had a fever, and then access to antimalarial drugs. At this point, we're not able to limit, what would be ideal is to limit this indicator to, of those children with a fever in the past 2 weeks that had an associated malaria parasite infection that received an effective antimalarial, because that's where national policies are moving. And this finding largely conforms to the Rollback Malaria Monitoring and Evaluation Reference Group recommendations, not to include the new questions on diagnosis and test result. And then we argue, if possible, survey data should be supplemented with data from health systems or exit interview surveys studies to get the proportion of suspected malaria cases where national policy on malaria diagnosis and treatment was followed. Because what you really want are two different things. Are kids getting access to health care for fevers that are potentially life-threatening malaria? And then what happened? We can measure ACTs pretty well, but there's still a little bit of a black box as to was national policy followed. And household surveys may not be the best place to get that data, get those data, but such things as health systems assessments and exit interviews through service provision assessments might be a worthwhile tool. I'll also just mention that this study was done among 5 clinics in Zambia. We think it's fairly representative of most of Zambia in the public health sector, but clearly there's a lack of external validity. And then I think when you move outside of Zambia, which does a pretty good job with its malaria control program, I think the external validity gets even weaker. And I think this would argue that further studies looking at the validity of these coverage indicators are really critical, especially the amount of money that's being spent on malaria control among donors and countries across Africa. So thank you, and thanks to Path Masepa, who was our partner in this, and we had funding from the Bill and Melinda Gates Foundation to implement this study, a big thanks, and then all of the participants in Takehome District and then the District Health Management Team in Zambia is thanked.